Welcome to the short training video that will help you and your crew understand and ultimately implement the principles of cardiac arrest management, or CAM. CAM is a pit crew approach to running a code in the field. By coordinating all the resources on the scene, the chances of the patient in sudden cardiac arrest surviving to hospital discharge neurologically intact improves. The EMS systems in Ventura and Santa Barbara counties implemented CAM for their sudden cardiac arrests. In Ventura County, the survival to discharge rate for witnessed ventricular fibrillation arrests jumped from 32 to 52%.
150.
Our goal is to optimize our team's performance during cardiac arrest management. In order to do this, let's look at each of the following key points in detail: role assignment, the triangle of life, high-quality compressions, prompt defibrillation, airway and ventilations, and advanced life support. When a two-person team arrives first, Rescuer 1 immediately goes to the patient's side and begins to assess the patient's level of responsiveness. If no response is detected within 5 to 10 seconds, Rescuer 1 begins high-quality chest compressions immediately. Rescuer 2 sets a metronome to beat 110 times a minute. Rescuer 2 kneels next to the patient opposite Rescuer 1 and applies the AED multifunction pads to the patient's chest while chest compressions are being done. After the AED is placed, compressions are briefly stopped while it analyzes the rhythm. If no shock is advised, continue CPR for 200 compressions. If shock is advised, perform 30 compressions while the AED charges. While defibrillating, maximum time off the chest is 5 seconds. A non-rebreather mask is placed over the patient's mouth and nose with oxygen delivered through passive ventilations.
Start CPR.
1, 2, 3, 4, 5, 6, 7.
When it is a three-person team, the third rescuer kneels at the head of the patient and uses a BVM to deliver one breath every 10 compressions. A pediatric-sized bag may be used to help control volume. Rescuer 3 holds the mask with 2 hands while Rescuer 2 squeezes the bag. Rescuer 3 counts off every 10 compressions, adding them up to 200 before directing the team to analyze the rhythm.
58, 59, 60, 61, 69, 10, 190.
Chest compressions are tiring. Team members must rotate every 2 minutes so that compressions are consistently administered with enough force and with adequate rate.
4, 5, 6, 7, 8, 9.
Paramedics should switch to a manual defibrillator and continue to monitor the patient's rhythm during the cardiac arrest.
1, 2, 3.
High-quality chest compressions are essential to survival. Chest compressions must be between 2 and 2.5 inches deep at a rate of 110 beats per minute. Do not rest your hands on the chest wall in order to allow full chest recoil.
2, 3, 4, 5.
Ventilations are provided using a BVM. A pediatric BVM can be used to reduce the chance of gastric distension. Ventilate at a rate of 1 breath for every 10 compressions. Ventilate on the upstroke of the compressions. The compressor should count out loud. Avoid using an advanced airway unless you are unable to maintain patency with a basic airway.
50.
End-tidal capnography should be used as soon as it is available. It can be placed in line with a BVM or with an endotracheal tube. Studies show that the sooner ventricular fibrillation is recognized and treated, the more likely it will convert. Defibrillate the patient as soon as possible. Remember to continue compressions until the moment of defibrillation, then immediately resume compressions. In the initial phase of a cardiac arrest, the focus is on high-quality chest compressions and early defibrillation. ALS procedures such as an advanced airway, IV access, and medications should be done without interrupting compressions and delaying defibrillation. Intraosseous access is less likely to interrupt chest compressions and can be rapidly achieved. If return of spontaneous circulation is achieved, the focus shifts on stabilizing the patient's life threats and coordinating transport efforts. Obtain a 12-lead EKG prior to transport. 5 to 10 minutes on scene is reasonable to ensure rhythm stability. Ventilate the patient about 10 times per minute and achieve an EtCO2 reading of 35 to 45 and an SpO2 reading of 94 to 98%. Do not hyperventilate or hyperoxygenate. Aggressive resuscitation should occur for at least 20 minutes before terminating efforts, except in rare circumstances such as unsafe and unworkable scenes. In these cases, attention turns toward any family or friends who may be nearby.
Hi, this is Chris Gosner. I'm here to talk to you about death notification. With the new CAM policy, there's a chance we may be leaving more cardiac arrest victims on scene. So death notification is something that we should really talk about, talking to the family. Statistics show that even before this, 60 to 80% of out-of-hospital death notification was done by paramedics and first responders. The police and the military make up the other 20 to 40%. So it is something that we should review. When you're managing a cardiac arrest scene, you're usually in a resuscitation phase, which is usually an impersonal, task-oriented phase. It's very high intensity. When it comes to the communication phase and the death notification phase, it becomes a more slow-paced, personal, and intimate phase. During CAM, there are some steps that the paramedic or captain can use to better prepare the family for the news at the end. Don't automatically exclude family from watching the resuscitation unless they interfere with your efforts. Don't use complex medical terms. Use your history gathering to help prepare the family for a possible pronouncement. It matters less who does the notification than how the news is delivered. Put yourself on the same level as the family member, sitting or standing, and make eye contact. They'll remember every word and action later. Use the D word, dead, died, death. It helps the patient family to avoid denial. Deliver the news quickly, don't drag it out. If resuscitation was started, reassure about the efforts, like we did every medical procedure possible, but were unable to revive him. Pause for survivor response. Touch the family member's arm, hand, or shoulder. It's a sign of support. If you're comfortable, hugging works for some, but make sure you gauge the situation appropriately first. Listen to them, offer them water, offer to call relatives or a minister for them, offer chaplain services. Explain the role of the police arrival. If you transport, don't leave them without a ride to the hospital. You can use helpful phrases like, "I'm so sorry for your loss. I know this is very painful for you. How can I help you?" Some phrases that have proved to be hurtful are, "It was actually a blessing because," "You must get a hold of yourself," "I can't tell you that," "Things always work out for the best." Phrases that can be hurtful are, "I know how you feel. My so-and-so died last year," or "She had a full life," or "At least he died in his sleep." Try instead to use the phrases named earlier. When it comes to family members and pronouncing the cardiac arrest victim on scene, family members of transported patients expressed less positive interactions with EMS and hospital staff, felt anxiety rushing to the ER, felt alone waiting for any information, and felt frustration in going to the hospital where patient was often declared quickly. The ability of the family to be present during the resuscitation facilitated their adjustment to the death and the grief process. Some expressed that he or she would have wanted to die at home and not at the hospital. So when it comes to the keys to success in a death notification process, always use understanding, caring, compassion, empathy, support, and advocacy. Your dispatch and the police department both have the ability to obtain chaplain services if needed. If you have any further questions about the CAM policy or death notification in general, you can email us at the Coastal Valley's EMS Agency website. Thank you.